We are live, doctor. You can start the session.
Yeah, thank you, Sai sir. Is my screen visible, Anujit?
Yes.
Yeah. Thank you once again to all the attendees. So we are yet again back with another UC Journal Club, and the session highlight today is decoding dry eye, and we have a good lineup of presenters, monthly mentor, and we have a stalwart in dry eye and cornea, Dr. Srinivas K. Rao sir, along with our dynamic UC members. And so the OC Journal Club publish or perish a call to action was started 3-4 years back. And this is the team which is currently taking the things over. So we have the Dynamic Governing Council by our President, Dr. Devakant Mishra. And we have a good dynamic executive team as well. And this is the concept of the Journal Club is to learn and grow. And we have tailored the Journal Club in such a way that it benefits a young ophthalmologist from fellows, postgraduates, be it first year, second year, and third year, on how to interpret a journal article, reading between the lines, and helping to understand even biostatistics as well. We do these kind of problem statements like definition of the problem, defining the variable, selection of subjects. So the monthly mentor and the presenter will be allotted with each other, and they tend to interact like a mentor-mentee with the MAARIE format, the MARI format. And this is the format that we tend to follow, where we have the moderators and the research expert for the webinar, but most of the work is a month kind of a work that the monthly mentor and the presenter tend to do in the background. And the panelist also adds their view. And today we have a keynote lecture followed by expert opinion as well by Srinivas sir. So this is the MARI format which we use for step-by-step approach. And this is our dynamic team. I'm in charge of the journal club along with a very dynamic team members that we have, more than 6-7 team members we have. And if any one of you are watching it, every month we have this journal club. You can just put a mail to us or you can ping us, and you can also be part of this journal club. And the QR code that you are seeing on your screen, you can go back to all the archives that we have. We do one journal club every 1 month, and you can access all the videos. And this is again the Google Forms that you need to fill to be part of the panel. And it's a very inclusive journal club. You can also be on the other side. Just need to fill the Google form and you need to show your interest to us. And this is a small history where in 2021, we started with 4 episodes with glaucoma, cataract, ocular oncology. And in 2022, we had 5 episodes of different subspecialties. And then in 2023, you can see slowly, steadily, we had up to 7 episodes of Journal Club. And then we also started having with IJO Live Wire with Dr. Vanati ma'am, our editor of IJO, we started having interaction with biostatisticians. And, these are the 7 episodes of IJO Live Wire that we have done, each having different concepts, case reports, photo essays, original articles, reference management and avoiding plagiarism, publishing, and dealing with rejection was one of the topics. And, mastering RCTs, survey designs. So we left no stone unturned for a young ophthalmologist or for a avid researcher who's very passionate about research, along with our simultaneous subspecialty journal clubs, which we have once every month. And this was the last journal club that we had on biostatistics, where we had the HOD or the former HOD of the biostatistics department, Dr. R.M. Pandey sir. And these are some of the other subspecialty journal clubs we had. And today we have Dr. Srinivas K. Rao sir, and we'll be introducing each one as and when the webinar is going on. So first, I would like to welcome Srinivas K. Rao sir, SK Rao sir, who's an alumnus from Madras Medical College, and he's also a professor. He was a professor in Shankara Nethralaya from 1991 until 2004, and he's also a professor at the Chinese University of Hong Kong till 2006, and he founded his own center, the Darshan Eye Clinic, in 2006. And sir has many accolades to his credit, where he's trained in corneal diseases and surgery at LA, Dallas, Boston, and New York, phacoemulsification in Canada, and LASIK in Minneapolis, and keratoprosthesis surgery in Italy, and certified ICL implantation has been done with epidemiology and biostatistics in California. Sir's major interest is in dry eye and ocular surface diseases. and he was the first to do the MOOKP procedure in India and Asia. And he's on many advisory boards. You can see the uh, names here: Allergan, Alcon, Sandston, Cipla, to name a few. And he has attended 300 national and 75 international meetings and has delivered over 650 lectures. And he has published more than 200 articles in various peer-reviewed journals and authored more than 20 books and editor of A to Z book series. And he's also the ex-first president of Corneal Society of India, and he has outstanding service in prevention of blindness. He has done many orations. To name a few, the IMA oration, the Rustam Ranji oration, and gold medal in 2008, the Trivandrum Ophthalmic Club oration, and winner and recipient of many, many more named awards and named orations like the Dr. Joshi Memorial Lecture in Brunei, Dr. Narendra Swaroop Oration and Medal. We welcome you, sir. And I would like to hand over the proceedings to Niranjan, who was one of the brainchilds behind this conceptualization of today's event, who's also one of our core members. Niranjan, over to you to start the proceedings of today's journal club.
No, thank you so much. It is indeed our privilege to have S.K. Rao sir with us today. And uh, we are very delighted to have you, sir, join us for this meeting. So the usual flow of events is we start with the journal topic, sir, where the presenting and following that we'll be having the monthly mentor sharing his perspectives, and we have a couple of people on the panel whom I'll be introducing once the talk is done, and then we'll have the keynote lecture delivered by none other than S.K. Rao sir. So this will be the flow of events for today, and first, I would like to, since there is some technical issues with Dr. Shruti sharing her screen, I request Dr. Raghav to go ahead and share the screen while Dr. Shruti can present from that, which saves a little bit of time.
Dr. Niranjan, yeah, I think even I'm unable to share it. Can you please allow? I think there's a red box.
Manjula ma'am, can you give him the permission to share screen, if that's possible?
Niranjan, you can meanwhile introduce Dr. Shruti and Dr. Raghav.
Yes, sir.
Yeah.
Is my screen visible?
Yeah.
Yeah. So we welcome Dr. Shruti Devi S., who is a general ophthalmologist who's completed her MS Ophthalm from Chettinad Hospital and Research Institute, Chennai, and her MBBS from Sri Ramachandra Medical College, Chennai as well. She's presented posters and papers in state and national level conferences. So she'll be presenting today's journal topic as well. And then we have the mentor for the day. Next slide, sir. Yes. So Dr. Preetham RP. So Dr. Raghav Preetham is currently a cornea, cataract, and refractive surgery consultant at Sushila Netrayavaya Group of Hospitals in Nellore, Hyderabad. And he has completed his medical education from Kurnool Medical College and Masters in Ophthalm from India University of Health Sciences, Vijayawada, and fellowship in cornea and anterior segment from the prestigious LBPI. So he has several professional memberships, including the fellowship of ICO and MRCS Edinburgh, and he has multiple peer-reviewed publications and also many original articles and review articles in the area of scleral autoimmune diseases in PubMed Index journals. He has several accolades to his name, and this is the exhaustive list of the same. So we are very happy to have you with us, Dr. Preetham. So over to you. Dr. Shruti, are you ready?
Yes, sir.
Are you able to share the screen now, Dr. Preetham? Is it happening?
Thank you for the kind introduction, but sorry, I'm not able to share it. I don't know what the issue is because there is a red pop-up which is showing app.zoom.us.
Yes, sir. Similarly, even here it is like that.
Can you
I
just
guess,
mail the PPT, Dr. Preetham?
yeah, quickly I can.
Mail it to me, either me or Niranjan. Maybe we can take up the next one on the agenda, Niranjan, and then come back to the journal club. you or me can share it from our end once they mail it.
Okay. So can we have the
I'm
keynote, sir?
Yeah,
Mean-
we'll move like that. We'll not waste time. We'll move to Sir's talk, and then we'll do the journal club. And then,
Super.
yeah.
So we're delighted to have SK Rao sir's keynote like on dry eye cells. Sir, can we go ahead with your lecture, sir, if you're ready? Anyone, sir?
Are you seeing my screen?
No, sir, not yet, sir.
Not yet, sir.
Yeah, now, yes, sir.
Okay.
Yeah, perfect.
Yes, sir. Perfect.
So let me then get going. So thank you, Prasanna and Niranjan, and the other members of the YOSI team for inviting me here. I'm likely the oldest participant in today's program. Don't qualify for the title of a young ophthalmologist anymore. It was very nice to see the wonderful work that you've all been doing on the sites that Prasanna shared. I was asked to speak about dry eye today, and it's been one of my interests over the last 30 years that I've been treating problems of the ocular surface. And compared to when I first started in the early 1990s, we understand this condition and the ocular surface a lot better today. However, I still find that there is scope for improvement, and a lot of people tend to be very confused about how to go about assessing a patient who presents with symptoms of ocular surface discomfort. And I thought I'll spend the next 30 minutes that have been given to me trying to elucidate some of the points that I have learned over the last 3 decades or so. Now, dry eye is important in the current practice scenario in each and every one of our clinics because it is one of the 3 most rapidly growing eye problems in the aged. In the US, where we have good data, it accounts for 1 out of 4 visits. But because the prevalence of dry eye and meibomian gland dysfunction is more in the Asians, we can be reasonably sure that it accounts for roughly the same or possibly a little more in the context of our Indian clinics as well. And because of the increasing use of the video display terminals like we're doing today for our webinar, it is no longer a problem that is restricted to the elderly. We are now seeing an increasing burden in younger individuals as well. Even though it is a common problem, it presents many diagnostic challenges. And when a patient presents with symptoms of discomfort in the ocular surface, we must first consider if these symptoms represent a tear deficiency state itself. The problem with these symptoms is that they're quite non-specific, they're quite varied, and the patient may present to you with any one or more of these as well. However, in a busy clinic, sometimes it is easy to club together everything under the rubric of a dry eye. But please remember that if the primary symptom is a severe headache, drooping of the lids, polyopia, swellings, copious discharge, photophobia, severe pain, or a loss of vision as opposed to a fluctuating vision or disturbed vision, then it is very unlikely that the primary condition is a dry eye state. We can distinguish between these by looking at the symptoms in slightly greater detail, as I'll show you in the next slide. And when you look at the symptoms that way, you can also pick up conditions that coexist in many of these patients, which can mimic and or aggravate a dry eye state. And unless you recognize these and pick them up and treat them as well, the patient's unlikely to get better. In general, the dry eye onset is seldom sudden. The symptoms tend to be constant, although they can vary between the day and during the day. And over time, a dry eye will generally get worse. You're not going to have episodes where it gets better, recurs after 3 months, unlike a viral keratitis, for example. And usually, a moderate to severe dry eye is worse in the morning. You can think of it like a rheumatoid arthritis where you have early morning joint stiffness because there's no fluid in the joints. As the patient wakes up and blinks and stimulates the nerves, tears will flow and they tend to feel a little bit better. Generally, computer use, travel, and adverse environmental conditions will make it worse, whereas rest, where you don't have all of these things, and tear substitutes will make it better. And if there is a significant element of inflammation, steroids will help as well. We do need to consider these common underlying systemic conditions like connective tissue diseases, a dysthyroid state, Parkinson's, or a dry mouth as in Sjogren's, and the use of many systemic medications today, which can also potentiate and make this condition worse. Although the symptoms, like I said, are non-specific and non-diagnostic, it does help to quantify them in some way. So you can use one of the many questionnaires that are available. What I'm showing you here is the Ocular Surface Disease Index. It's a fairly simple questionnaire that the patient can fill when they're waiting in the waiting hall outside. Each of the questions, the response gives them a score. You put it as a composite score, and obviously the more the score, the more severe the condition. And in general, a cutoff of 13 is used. 13 or more is suggestive of a patient problem with the ocular surface and the tear film. This will also help you to monitor the patient's progress over time as you treat him. If it's getting better, you expect these scores to become lesser over time. Once you have a score of 13 or more and you think that you're dealing with a tear dysfunction, we need to identify the type. Why is this important? It is because the dry eye is neither a single or a simple entity, because there can be factors like environment, the physiognomy of the face, and work practices which can impact this. A tear dysfunction in an elderly person who's postmenopausal woman, as opposed to younger patients who work on computers, those who had surgeries, who have an underlying systemic disease or other contributing factors, each of this will form a different part of the spectrum. And as you shall see in the next few slides, the way in which you assess this condition, the tests that you do, and the definitions that you use will impact your recognition of this condition in your patients. And finally, even if you get through all this and recognize this, you must then be able to decide whether it's a problem with aqueous tears, with the lipid from the meibomian glands, with the mucin secretion or the epithelial surface of the eye, whether lid problems, tear turnover issues, inflammation, and a loose conjunctival state. Constantly, efforts have been made to standardize this whole thing so that people can come up with a diagnosis in a repeatable and reproducible manner. And one of the groups that has been doing a lot of good work in this is the DUCE group. And recently, about 3-4 years ago, the DUCE 2 protocol came up. Unfortunately, for the Indian context, this has not helped really very much. I'm sure all of you have seen this particular algorithm, which they give you in a systematic manner to assess the dry eye, recognize it, pick it up, and then decide which type it belongs to. And the main reason why it doesn't work too well for us is because they do not suggest the use of the traditional metrics that we are used to using in the Indian clinics. We use a Schirmer for tear volume. We use a fluorescein stained tear film for the BUT or tear stability. And we often put pressure on the lower lid to look at the expressibility of the meibomian glands to assess the lipid function in that particular eye. What the DUCE 2 suggests, however, is looking at the NIBUT, wherein a device projects a grid onto the tear film, and a breakup in this grid is used to time the breakup time. They want you to measure the tear meniscus height and also the lipid level in the tear film by doing interferometry. A redness score is considered useful, as well as infrared meibography to look at the anatomy and distribution of the meibomian glands themselves. And all of this is given as a nice composite report, and this is definitely useful. There is no doubt about it. We are quantifying the various metrics that we are using to assess the surface of the eye. The problem is there is a capital expenditure involved in buying these devices. And each time you do this, the patient again has to pay for you. So all of these things have to be considered in the context of a general ophthalmology clinic in the Indian context. But be that as it may, whatever these metrics are, ultimately what we are interested in is the health of the ocular surface and the impact of these various parameters on this health. So the simplest way to do that is to use these 1 rupee strips. We normally use fluorescein staining to assess the health of the corneal surface and epithelium, and either rose bengal or lissamine green to do the same thing for the conjunctiva. We use the blue filter on our slit lamps to look at the fluorescein staining of the ocular surface. And if your slit lamp also has a yellow filter, if you can put it in, then you can use the same fluorescein staining to assess conjunctival staining as well. You do not need a separate dye. So it is a worthwhile investment when you're buying your first slit lamp to try and get one which also has a yellow filter in it. Now, one of the elements that is not given its due recognition and which is often forgotten in the context of dry eye and the ocular surface is inflammation. And this is a paper that we wrote about 4 or 5 years ago. And I'm happy to share it with anybody who wants it. I can send it to Prasanna later. The thing is that when you have dryness and the cells are dehydrated, they tend to die. Now, this is different from apoptosis or pre-programmed cell death, which happens when the cell gets old and dies. This is a very orderly process. The cell dies, the next cell comes in and takes over the function. Whereas when the cell dies due to a dry eye, it is like a suicide bomber. He triggers the West and takes a lot of people around him along with him. So similarly, when a cell dies due to dryness, it takes care of a lot of the other cells. They also die. This produces inflammation. The inflammation will then go back and affect more of the cells, particularly the goblet cells producing mucin and the tear secreting cells. This potentiates the dryness, and this comes back and creates more inflammation. So these are two vicious cycles that are interlinked. Once this goes on for a bit of time, these inflammatory products include something called corneal envelope precursors, and these tend to produce a hyperkeratinization of the openings of the meibomian glands, which then get blocked. Once this happens, the mebum cannot come out, the back pressure builds, causes atrophy of the meibomian glands, and this brings meibomian gland dysfunction into the picture. So over time, no matter which starts first, the three will come into the picture, and these form interacting vicious cycles, which become self-perpetuating if not addressed in time. Recognizing inflammation on the ocular surface can be by using point-of-care tests like the tear lab for measuring osmolarity, the Inflammadry for measuring MMP9, but again, these come at a cost. We are interested in clinical methods. So ocular surface redness, especially if associated with conjunctival edema, is a useful metric for inflammation, as is the extent of conjunctival staining evaluated by the lissamine green dye. We can also look for the presence of lip cough, which stands for lid parallel conjunctival folds. Because the inflammation produces MMP9, this dissolves the subconjunctival stroma. And in a dry eye, when the lid blinks, there's a lot of frictional trauma when it translates across the ocular surface. And because the subconjunctival connections are loosened, the conjunctiva gets thrown into folds. And if you look at the lower lid margin, particularly in the temporal side, you'll see little folds of conjunctiva. And this is again a sign of increased inflammation on the ocular surface. So untreated dry eye, like I showed you, because of the vicious cycles, can very quickly become persistent, self-perpetuating, subjected to chronic inflammation. To address this, Rolando suggested that if the patient has symptoms only in response to a particular trigger, and this happens on and off, we suggest that he has sporadic symptomatology. If he has symptoms in response to a specific trigger, but this happens more often, then he has intermittent symptoms. If the symptoms are not related to any particular trigger and come frequently, it is persistent. And if they're there all the time, from morning till night, it is permanent. The importance of recognizing this is that if the patient has sporadic or intermittent symptoms, Rolando suggests that if you can treat such people early and aggressively, managing the tear film instability, the epithelial damage, and the inflammation, the three components of the vicious cycles, you can heal the ocular surface and exit the patient from this vicious cycle. However, if he comes to you with the persistent or permanent symptoms, the compensatory mechanisms have already been lost, and then the therapy is just more of maintenance and keeping the patient comfortable. Treating inflammation in the beginning for aggressive needs can be by using low potency or full strength steroids. But in the long term, because of side effects, we need immunomodulators. And fortunately, today in India, we have the whole spectrum, 0.05%, which was the first, and now 0.09% cyclosporine A, 0.03% and 0.1% tacrolimus. And the newest kid on the block is the 5% lifitegrast, which is also available in the Indian context now. All of these work on the T cell pathways, which are important components of the inflammation of the ocular surface. They work at different sites along this pathway, and therefore you can even combine two of these for additional effect. Usually they start working between 3 weeks to 3 months. And initially when you start these immunomodulants, because they tend to be slightly irritating, we initiate treatment with a 4 to 6 week of a low potency steroid like fluoromethalone or loteprednol, because this also brings in quick action, controls the inflammation that comes from the immunomodulator. And by the time you wean these off, the effect of the immunomodulator sets in, and you can maintain them in the long run more safely. We also learn to look for subtle clues in these conditions on the ocular surface. We know that tears are produced in the lacrimal gland and flow from the upper temporal to the nasal area where they get taken off the ocular surface. And therefore, the concentration of tear or the gradient is least in the nasal conjunctiva. If you have a garden variety dry eye, therefore, the first sign of dryness will be seen here where there is less tears. On the other hand, if you have an inflammatory subset, because the tears themselves contain the inflammatory mediators and the concentration is higher in the temporal region, in an inflammatory dry eye, you will tend to see initial staining more in the temporal bulbar conjunctiva. Oil or the lipid is a very important part of the tear film, and this is produced by the meibomian glands. And if you put pressure on the lower lid, if you see a lot of clear meibum coming out, we call that meibomian seborrhea, and this tends to be associated with a decreased wettability dry eye. The oil contaminates the corneal surface, prevents the water from getting retained, and the patient will have dry eye-like symptomatology. If the pressure produces this kind of a toothpaste sign, turbid, inspissated material, this is inflammatory, and the eyes tend to be red, congested, and this is when you will get the staph immune infiltrates and so on. And like I said, in long-standing inflammation, if the gland openings get blocked off, no sebum is excreted when you put pressure on the lid, and this will result in an evaporative dry eye. Apart from housing the meibomian glands, the lids have other important roles to play because of their because the lids have a close relationship with the ocular surface. If you have a dysfunctional blink reflex, this will result in poor tear clearance because it's the blink which pumps the water off the surface. It is also the blink which squeezes using the muscle of Riolan, the meibum onto the surface. So when you have poor tear clearance and retention of all the muck on the surface, you will get inflammation, the patient will complain of constant watering, and the corneal surface and the tear film will have a lot of debris in it. Normally, the lower puncta are in close opposition with the globe. Here, I'm not pulling the lower eyelid down. It is a picture taken just as is, and you can easily see the openings of the puncta in the lower lid, which means that the lids are everted and there is punctal eversion. This will lead to poor tear clearance. And as you can see, there is retention of fluorescein in the tear meniscus for a long period of time, and there is associated inflammation of the ocular surface. The lid viper refers to the terminal 1 to 2 millimeters of the upper lid border, and this is the surface that has 90% of contact when the lid moves across the surface. In a dry eye, because of the increased friction that happens when the patient blinks without the tears protecting the surface, over time, metaplastic changes will occur over here, and this will result in changes in the superior bulbar and the upper half of the cornea, and this has been termed lid viper epitheliopathy, and in the later stages, superior limbic keratoconjunctivitis. These are the lid parallel conjunctival folds, and when they become even more prominent, we call it conjunctivochalasis, and these interfere with the position of the tear meniscus and the tear turnover. And finally, these kind of loose, bulgy eyelids, which is termed dermatochalasis, is because of a loose orbital septum. And in the presence of a loose orbital septum, there is orbital fat prolapse, and this again results in a dysfunctional blink reflex. So all of these conditions must be looked for in addition to the tear deficiency itself. Traditionally, we look at staining on the corneal surface, and I think this, for me, the most important part of my dry eye assessment, because this reflects the ocular surface damage in the eye. Van Bijstervel scoring requires the presence of two vertical lines, temporal 1/3 bulbar conjunctiva, 1/3 cornea, nasal 1/3 conjunctiva. Each gets scored between 0 to 3. 0 means no stain, 3 means total stain. So it's a semi-quantitative method. So you get a score of 0 to 9 for the ocular surface. For the cornea, I also like to use two horizontal lines and divide it into 3 parts because I need to know the scoring from 0 to 9. But I also want to know whether it is primarily in the upper 1/3 in the middle 1/3 or the lower 1/3 or globally distributed. In the lid, like I told you, this is the lid viper. And when you have a lid viper epitheliopathy, you can see this kind of staining, which you can grade according to the width and the extent. And in the lower lid, with rose Bengal, you see a spotty line of staining, which is called the line of marks. This is another useful clinical sign, and I'll explain this with this expanded view of the lower lid margin. This is the posterior margin. These are the meibomian gland orifices. And normally, the meibomian gland orifices secrete a small amount of oil or meibum. And this, because of its surface tension, keeps the tear meniscus in place. And the rose Bengal staining, this line of dots, reflects the position of the tear meniscus. And this is called the line of marks. If you have an aqueous deficit, there is less tear meniscus, which goes posteriorly. And to mirror this, the line of marks will also move posteriorly. On the other hand, if you're starting off with an evaporative dry eye where there is very little meibum coming out of the meibomian glands, the surface tension is not enough to keep the tear meniscus in place. The tear meniscus will spill over more anteriorly, and the line of marks will also then move more anteriorly. So these are the kind of subtle signs that you want to be able to learn to recognize and pick up to try and distinguish which type of dry eye you're dealing with on the surface. Now, if you have a patient with a very poor Schirmer with a lot of staining and the patient complains of pain, it's very easy to understand. This is neurogenic. The impacted surface is affecting the nerves and the nerves are causing pain. On the other hand, the patient complains of terrible symptoms, but the Schirmer is normal. You don't see significant staining. And what you must look at is the breakup time, because there is an entity called the short breakup time dry eye or the short BUT dry eye. And this is responsible for the patient's pain in some instances. But if you look at the BUT, and the BUT is normal as well, the Schirmer is normal, there is no stain like I told you, but the patient complains of significant symptoms in this context, you then consider the possibility of neuropathic pain, which means that the nerves are responding in an abnormal manner to normal stimuli. In some of these patients, this may be associated with deficiencies of vitamin D and vitamin B12, or some kind of a surgery on the ocular surface like corneal refractive surgery. But if you've ruled out all of this as well, then finally we may have to consider that the patient has psychogenic pain, where he is responding inappropriately to whatever is happening on his ocular surface. But I can tell you that in most patients, it can be very challenging to distinguish between neuropathic and psychogenic pain, and this must be a diagnosis of last resort. I'm going to take the next 5 minutes that I have to take a little more detailed look at the mechanism of tear film formation, because after all, we're talking about dry eye, and this has to do with the tear film, and I'll show you why this is important and why it's worth spending 5 minutes. When the eyelids are closed, the upper lid is in contact with the lower eyelid and with the tear meniscus, and when the blink happens and the eye opens, basically it tends to drag the tears along with it in an upward direction, and the thickness of the tear film here is directly related to the radius of the tear meniscus, the viscosity of the tear, the rapidity of upper eyelid movement, and inversely related to the surface tension of the tear. So this is the first movement. When the eye opens, the aqueous tears are moved up because the upper lid drags it up along with its movement. There is a second movement that also occurs. The first movement results in a tear film that is thicker inferiorly and centrally, because the surface tension of the lower lid tear meniscus keeps holding it down, and therefore the tear film is thinner in the upper parts, which is why in lid viper epitheliopathy and SLKC, a lot of the changes occur in the upper half of the ocular surface. Once the first movement has occurred and this aqueous tear film has formed, the tear film lipid layer continues to remain in the lower meniscus because it can't move unless the aqueous phase has been established. So once the aqueous phase has been established, because of the gradient in the tear film lipid and the Gibbs-Marangoni effect, the lipid starts to move upward in a second movement, and this also will drag the aqueous tears upward along with it. But as it takes the tear upwards, when you come to the convexity of the cornea in the center, because of the surface tension holding the tears back from the lower lid, there is a transient dimple that will occur in the center. And after these two movements are completed, you will get your final stable tear film. So why have I talked about this? Why is it important? Basically because we have to first understand the tear film itself, and then in a tear film problem, we need to recognize which component is affected. When I started 30 years ago, I was taught that the tear film is a tri-layered structure. There is mucin, there is aqueous, and there is oil. That concept has changed. We now know that the epithelium has microvilli and a glycocalyx which binds the membrane-bound and secreted mucins like MUC16. And then 90% is a hydrated mucogel where the aqueous has the dispersed soluble mucins like MUC5AC. And on top of it, we have a very thin film of oil. So when you have a tear film breakup, what all can go wrong? One, you may not have enough oil and therefore there is rapid evaporation. Two, you may not have enough aqueous tears and therefore there is breakup. Three, excess oil can contaminate the epithelial surface, preventing the water from holding on and cause a breakup. Four, you may not have enough mucin coating the epithelium, causing breakup. Five, there may be epithelial cell loss or damage, and therefore there is no stable tear film. And of course, there can be a combination of any of these five as well. So with this information, we now look at the Japanese way of assessing a tear film function. So this is the first movement that I told you. When the upper lid moves and takes the aqueous tears with it, we see what happens. Basically, there is no movement of aqueous at all. Your eyelid opens, you're just seeing a lot of corneal staining. This is a severe aqueous deficit dry eye. The Japanese call it the area break. And because of severe aqueous deficiency, you're seeing the damage on the corneal surface as well. The second type is also during the first movement when the lid goes up and takes the aqueous along with it. There is a movement of fluorescein stained tear film, as you can see, but there is poor retention. You're seeing these areas of break. This is called the spot break, and this is a decreased wettability dry eye. The third type happens during the second phase. The lid goes up, the aqueous has formed, and then the maintenance of the aqueous during the second phase is what we are looking at. You can see that the aqueous goes up, but then it starts to break down in the inferior part due to a rapid thinning of the tear film. This is suggestive of a mild aqueous deficit dry eye because the surface tension is pulling it from below, causing it to thin, and this is called a line break. In the fourth example, again the second phase, there is a movement, aqueous tears go up, but there is a problem here in the center of the cornea where I told you that when it goes up, there is a dimple that forms. So this dimple is getting exaggerated. The tear film is breaking up here. This is called a dimple break. And this again is an example of a decreased wettability dry eye. And the final example, the tear film is formed, is established, but then because of increased evaporation, we see breaks occurring at different parts of the tear film. And this is what is more closely related to our traditional static BUT. This is the evaporative dry eye caused by a random break. The Japanese call this the tear film oriented diagnosis, or TFOD. We use fluorescein stain, but unlike the static BUT that we are used to doing all along, this is a dynamic evaluation. We want to look at the timing of the break, the location of the break, the pattern of the break, and the expansion. So to reiterate, in a severe aqueous deficit dry eye, there is no movement at all. It's an area break. In a moderate aqueous deficit, the tear film forms, but then it thins rapidly in the inferior part where it's called a line break. If you get a spot, it's called a decreased wettability dry eye, and a dimple is also suggestive of the same. If you get a line which then expands very rapidly, it's a combination of aqueous deficit along with decreased wettability. So the thin film breaks down over a large area very quickly, and a random break is suggestive of an evaporative dry eye. The same information regarding which part of the tear film is affected can also be got from our own traditional metrics. The BUT represents a mucus health, Schirmer is the aqueous health, and by looking at the lipid, we're looking at the oily layer as well. So based on these three parameters, we can call it an aqueous deficit dry eye preclinical or clinical, evaporative dry eye preclinical or clinical, combined, or the short BUT dry eye. So once you've done this with either method that you want to use, look for the presence of inflammation, look for the presence of ocular surface staining, which represents damage, and the various other conditions that I told you about. Of course, only when you put all this together will you have a clear understanding of what is happening on the ocular surface. And only if you have a clear understanding of what is happening on the ocular surface can you then achieve a satisfactory treatment of that patient's dry eye problem. So final slide. you have to first identify what is happening on the ocular surface. And I've tried to share with you the symptoms, the signs, the tests, the small clinical findings that you can use. On the right side, you have the various treatment options that you have. I seldom agree with the concept of stage 1 requires the first 3, stage 2 requires the next 3, stage 3 requires the next 2, stage 4 requires everything, because dry eye is not as simple as that. So what I like to do is, once I've identified what are the problems, I will then pick up from here the elements that will treat that particular aspect of the problem. So for a particular patient, I may use 1, 3, 5, and 7. For somebody else, I may use 2, 3, and 8, and so on. And I call this the mesh approach. So you individualize your treatment to each patient. And the last concept is that of the step ladder. If you have mild disease, you start with a minimum treatment. And if it doesn't respond, you can go up the ladder by adding other medications. But like Rolando said, if you have somebody with severe disease, you want to get him out of the cycle as best as you can or as fast as you can. You throw everything you have into the mix. You start at the top of the ladder. And as he improves, you try and remove them one by one. So ideally, at the end of the day, you want to be in the middle of the ladder with some kind of a combination of treatment which is cost effective and which is possibly sensible for the patient to use. He can't keep using drops every half hour for the rest of his life. So this is the step ladder and mesh concept as far as treatment is concerned. So that's pretty much what I wanted to share today regarding dry eye essentials. Thank you very much.
Thank you, sir. Thank you so much for such a wonderful, comprehensive approach to dry eye. I mean, there could be no better person to dissect dry eye for us better than this. Thank you. Thank you so much for this detailed lecture. So it is indeed our privilege to have listened to you for the past 30 minutes, sir. Thank you. So we'll move on to the presenter, Dr. Shruti, if you're available. And Dr. Shruti wants to.
And Srinivas sir, if possible, you can also help us decode the paper, sir. We have a paper.
Yeah, I'll be.
Yes, sir. And do guide us if you have time, sir. Thank you. Thank you for the enlightening talk, sir.
My pleasure.
It will be in an archive for all the young ophthalmologists, and it will really help them in their dry eye journey. Thank you, sir.
Thank you.
Sir, I'm not able to share my screen, sir.
That's
Niranjan,
fine.
you can
That's
share a screen, Niranjan. It
Yes, sir.
will be better because I think there is some issue with the screen.
Yes, I'm ready with the PPT.
You can share and then you can keep changing the slides as and when Dr. Shruti wants you to change.
Totally.
Good evening, everyone. Can I start, sir?
Yeah, please.
Yeah, please start, Dr. Shruti.
Good evening, everyone. This is Dr. Shruti Devi S. from Chennai. I thank the entire YOSI team for this opportunity to present in this forum. And I'm delighted to be a presenter in this interesting session, Decoding Dry Eye. Next slide, sir. So dry eye disease is the most common complication which is seen post corneal laser or refractive surgery. And it's one of the leading causes of patient dissatisfaction, and it has a significant impact on the patient's quality of life. So here is a tabular column which depicts the incidence of dry eye in each kind of refractive surgery. So this shows the incidence of dry eye post 6 months. So in LASIK, as you can see, it's 20%, which is the highest. And in PRK, it is around 15%, and it is least in smile surgery. Next slide, sir. And etiopathogenesis of dry eye disease post-refractive surgery. Actually, the etiology is multifactorial in nature. So the base is that there is basically corneal nerve transection, which impacts the corneal blink reflex and results in reduced tear secretion and causes tear film instability, and thereby resulting in the hyperosmolarity of the tear film. And there is upregulation of the inflammatory mediators like the interleukins and the matrix metalloproteinases, which activates the inflammatory cascade, causing the goblet cell loss and the epithelial damage, manifesting clinically as the dry eye disease. Next slide, sir. So basically, what is IPL therapy? So IPL is nothing but the intense pulse light therapy. So here it comprises of a xenon lamp, which emits a light of wavelength between 500 and 1200 nanometer, basically targeting the cutaneous phase sebaceous glands. So here the IPL treatment intensity, it is targeted based on the Fitzpatrick skin scale from 1 to 6. So as you can see in this tabular column, the IPL is employed only for Fitzpatrick type 1 to 5, and for Fitzpatrick type 6, it's not applied. So basically, an ultrasound gel is applied over the targeted area, and an opaque goggles are worn over the eye before starting the treatment. And the interesting part is that IPL was initially used in the treatment of the vascular lesions like telangiectasias, and it has evolved over the years, and it was used in dermatology to treat the pigmented lesions like acne rosacea. However, in our ophthalmological setup, it is basically used in the treatment of dry eye, basically the meibomian gland deficiency, and also helps in eradicating the demodex mites. Next slide, sir. So basically, how does the IPL work? So it enhances the meibomian gland function by liquefying the meibum and promotes the meibomian gland architecture. And also it has an effect on the inflammatory markers and immune cell mediators as well. And basically, eyelid telangiectasia is a common condition which is prevalent in dry eye disease patients. So here, IPL, it destroys the abnormal blood vessels as well. And it inhibits the metalloproteinases, which predispose to inflammation. And it also has a role in photomodulation as well. Next slide, sir. Now coming over to the article for discussion titled Perioperative Intense Pulse Light to Prevent and Improve Symptoms of Post-Laser Corneal Refractive Surgery Dry Eye, a randomized clinical trial, which was published in the Asia Pacific Journal of Ophthalmology in 2024 with an impact factor of 4.4. Next slide, sir. So here, the rationale of this study was to elucidate the value of the perioperative IPL therapy for the prevention of post-operative ocular surface disease in patients undergoing lamellar corneal laser refractive surgery, the SMILE procedure, and the femtosecond laser-assisted in situ keratomileusis. So basically, they just wanted to see how efficacious the perioperative IPL therapy was in prevention and treating the post-surgery dry eye. Next slide. So here the methodology. So it was a triple-blinded, randomized, placebo-controlled clinical trial, and it was conducted in Spain. And the study was done over a period of 2 years. And the statistical software which was used was SPSS 26.0. And here the randomization was done by dichotomic sequencing 0 and 1 using computer software. And the sample size was calculated based on the non-invasive tear breakup time, accepting an alpha risk of 0.05 and a beta risk of 0.2 in a two-sided test, such that each group had a minimum of 25 participants each. Next slide, sir. So here, the treatment protocol was that the study population comprised of 61 patients undergoing refractive surgery, either the LASIK or SMILE, and they were randomized into two groups. Basically, the study group, which is the IPL group, which had 31 patients, and the placebo group, which had 30 patients. And they were followed up for a period of 6 months. Next slide, sir. So intervention. So the IPL therapy was administered using the Luminous M22. So how were the sessions actually spaced? So the first session was given 1 week prior surgery, and second session was given 1 week post-operatively, and third session was given 3 weeks post-operatively. So here the placebo group received sham IPL with identical settings, but here there was no energy emission. So these three images show how the IPL therapy was administered over the 3 sessions. So as you can see in the first picture, a double pass technique of 12 impacts were placed over the infraorbital region and the lower eyelid region using a wavelength guided filter. And in the second picture, you can observe a single pass technique of 6 impacts over the lower eyelid region using a wavelength guided filter. And in the third picture, you can observe a double pass technique of 3 impacts over the upper eyelid, which was given using guided wavelength filter. So here, the corneal surface protector was not used and the meibum was not expressed after the IPL was given, fearing the risk of any injury to the trauma to the flap in the immediate post-operative period. And this study was triple-blinded, wherein the patients, the treating physicians, and the outcome assessors were masked. Next slide, sir. So here, the patients who were included who were ideal candidates for laser corneal refractive surgery, aged 18 and above, and who possessed a skin Fitzpatrick scale of 1 to 4. And the exclusion criteria was patients who were not ideal candidates for laser corneal surgery due to pre-existing corneal surface disease, or patients who had vernal atopic keratoconjunctivitis, or patients with personal history of autoimmune diseases. Pregnant and lactating mothers were also excluded, and skin Fitzpatrick scale of 5 to 6 were also excluded from this study. Next slide. So outcomes which were assessed can be categorized into primary and secondary. So the primary outcomes were the ocular surface disease index score, the non-invasive tear breakup time, the tear meniscus height, and mammography score. And secondary outcomes were the visual acuity, refractive error, corneal topography and aberrations, ocular redness, and slit lamp findings. The follow-up duration, so here the tests were done from the baseline 1 month, 3 months, and 6 months post-operatively. Next slide, sir. So statistical tests which were employed for this study included the Shapiro-Wilk test to assess the normality of data distribution, the chi-square test for categorical variables, and the independent sample t-test to compare the continuous variables between the IPL and the placebo groups, and the repeated measures, the ANOVA and the Friedman test to evaluate the within-group changes over time. And a p-value of less than 0.05 was considered to be statistically significant. Next slide, sir. So moving over to the results. So with respect to the visual and refractive outcomes, there was no statistically significant differences between the study group and the control group. And there were no differences between the visual parameters as such, like the visual acuity, the refractive errors, and the corneal aberrations. Moving over to the dry eye parameters, namely the OSDI score, the tear meniscus height, tear breakup time, and mammography showed significant statistical changes. Next slide, sir. As you can see in this graph, the OSDI score at 3 months post surgery, the patients who were administered IPL had a better OSDI score with a mean change of -8.47 compared to the control group. And the tear meniscus height was also elevated in the patients who received the IPL therapy by 0.05 mm. And the infrared mammography scores were also lower in those patients who received the IPL therapy. Basically, the mammography score, lower the score, better the ocular health surface. And similarly, in 6 months post-operatively, there was a significant improvement in the OSDI score, tear meniscus height, which was 0.06 mm, and the non-invasive T-bud time elevated by 1.682 seconds in the study group. And mammography scores eventually improved. Next slide, sir. Now, while comparing our study with the previous studies and approaches done previously, so in a study done by Zhao et al., where IPL was administered 1 week before the SMILE procedure, showed a lower post-op OSDI score and a better T-bud at the first and 3 months post-operatively. So this concluded that IPL had a preventive potential in treating dry eye. And another study conducted by the Yuan et al., where IPL was administered after the LASIK procedure, showed symptomatic relief after dry eye developed. So here, IPL is still effective post-op, but less preventive. And artificial tears and cyclosporin, which is used in the routine post-op management, had temporary relief and required frequent dosing. Thus, IPL offered more sustainable device-based relief. On the other hand, LipiFlow thermal pulsation, which was a device-based MGD therapy, it improved the meibomian gland function over time, but the drawback was that it was more expensive and less focused than the IPL. And punctal plugs, they were used to retain the tears in the post-operative period. However, they also had a predisposition to the risk of infection and offered transient benefit. While IPL, it targeted the root causes, namely the inflammation and meibomian gland deficiency. Next slide. So the author derived his conclusion by stating that the IPL treatment was significant in improving both the subjective symptoms in terms of the OSDI scores and the objective signs, the tear meniscus height, the non-invasive tear breakup time, and the mammography. And it also served as a prophylactic strategy to reduce the incidence and severity of the post-operative dry eye in patients undergoing LASIK or SMILE. Next slide, sir. So the strengths of this study was that it was the first randomized controlled trial to assess IPL as a prophylactic strategy in refractive surgery. And it was triple-blinded study. And it measured both the subjective and the objective outcomes as well. So limitations were that it was a single center design. So that is, it limited the generalizability to other settings and population. And the sample size which was taken was also small. And the duration of follow-up period was also for a short to intermediate period. And demographic data was also limited. And there was no subgroup analysis, wherein the effects by surgical type, say being the LASIK or SMILE, the intergroup differences were also not explored. And also how feasible will this routine perioperative IPL therapy be in clinical settings also remains unclear. Next slide, sir. So the perioperative IPL therapy is effective in preventing dry eye symptoms, and it is extremely safe with no adverse effects reported. And it's applicable to both the LASIK and SMILE procedures as well. Next slide, sir. So my interpretation of this study is tabulated in a MARI format. So the methodology. So here, the study question was well defined and the study hypothesis was appropriate. And the study type, it was a prospective interventional study. However, the sample size was inadequate and the follow-up period was also for lesser duration. A study could have been done in a generalized population. Next slide, sir. Assignment, the randomization and the sample size calculation was precise and well defined, and the patients were regularly followed up in that specific time period. Next slide, sir. Assessment, both primary and secondary outcomes were assessed, and it was appropriate and accurate. However, the duration of the follow-up period was shorter. Next slide, sir. So moving over to the results, the statistical tests which were employed were appropriate, and the confidence intervals were also well defined. Moving over to the interpretation, the perioperative IPL therapy is efficacious in improving both the subjective symptoms as well as the objective signs of the dry eye disease post corneal laser refractive surgery patients. So thus, it's seen as a provocative and a promising measure to mitigate the incidence of dry eye in refractive surgery patients. Moving over to the extrapolation, since it's a single center study, it limits the generalizability, and further multi-center studies with larger cohorts are also recommended. And the cost effectiveness in the perioperative clinical settings needs to be warranted. Next slide, sir. So the clinical implication is that the perioperative IPL therapy serves as a significant step in exploring the preventive strategies for dry eye disease post-refractive surgery, and also helps in enhancing the patient comfort and ocular health surface post-surgery. However, further validation in larger and diverse population is needed. Thank you. And I thank my mentor, Dr. Raghav sir, for giving me the inputs in creating this presentation.
Thank you, Dr. Shruti. Thank you so much for the detailed explanation and presentation of the article. Over to the mentor, Dr. Raghav Pritam, for your inputs and your views.
Thank you, Dr. Ranjan. Firstly, thanks to YOSI for giving me this opportunity, and Shruti, congrats for an excellent presentation. So the reasons why we chose this article, because it was a very robust done randomized control trial with all the details very well elucidated in the article. So I thought it would be better for the residents or the fellows to follow the article because all the details were very well done. Second thing, there are many studies for lubricant, cyclosporine, diclofosol, omega-3, vitamin D, but IPL is not very well explored in terms of using as a treatment protocol for dry eye post-refractive surgery. Then another point which adds is about the pre-treatment with IPL and how it can help prevent post-operative dry eye. So strictly we'll just try to talk about what are the important points in the article, like what Shruti explained to us. They saw that FS LASIK and SMILE both had similar kind of a dry eye profile and also similar kind of results in terms of dry eye with or without IPL. The refractive error and IPL therapy did not show any correlation. The peak amount of symptoms in terms of subjective symptoms was seen at around 3 months, but however, the symptoms died down by the time of 6 months. The objective signs were definitely more in comparison to the subjective signs. To summarize the shortcomings of this article, then we have only a single ethnic group, which are the Caucasians, which were included in the study. The more pigmentation of the skin, the more chance that the IPL fails. So it has to be again be done in a different diverse group, and it is a much more homogeneous sample. And we have also not looked into what were the exact refractive errors, what was the range of refractive errors, was it done in higher myopes as well, which was not clear in the study. They have done a GE between statistical significance, but values are very close. Although they show that it is statistically significant, the values, the numbers are really very close to comment whether that would make a clinical significance out of it. One other additional point which could have been done better in the study, according to me, is to include a confocal analysis of the basal nerve fluxes, because constantly the article kept saying that there is transection of the nerve, probably the reason for the neuropathic pain uh, included in the study, which was not looked into. So IPL per se independently is one of the tools for refractive for dry eye, but its role in preventing and its role in therapy is yet to be seen how it will transcend. So that was one of the reasons why we looked into this paper. I would appreciate any more comments about the article or any of the other aspects of the article as well.
Yes, yes. Thank you. Thank you so much, Dr. Preetham, because this has been a wonderful, innovation. The IPL and being analyzed to such extent is giving us a lot more of a perspective on treating the post-LASIK and post-refractive surgery dry eye. So we do have a couple of panelists who are joining us today to share their perspectives on the article as well. First up, we have Dr. Rakshit Nathan Rajgopal, who is a consultant cornea, cataract, and refractive services at the Eye Foundation, Coimbatore. So he's done his MBBS at PSD Institute of Medical Sciences and DNB Ophthalm from Arvind Eye Hospital, Teni. He's completed his fellowship with the ICO and in cornea and anterior segment at LBPI Hyderabad. So he has peer-reviewed publications in microbial keratitis, cornea, and ocular surface, and has several awards like the third place in APAO AOS Open Quiz, winner of Kera Quiz, and many more to his name. So we are very happy to have you with us, Dr. Rakshit. And let me also introduce the next panelist for the day, Dr. Amog Lakshman Jambagi. So he is currently a fellow in cornea, cataract, and refractive surgery. And he's done his MBBS from KIMS Hubli, MS from RIO at Chennai, and he's currently doing his fellowship with the Joshi Eye Institute, Hubli as well. So he's done more than 100 keratoplasties, 50 patch grafts, more than 1,000 phacoemulsification, and 50 refractive surgeries. He is also the student editor of TAJOSR, Best Paper Session, Cataract AOC, Best Physical Poster, runner-up ET Selvam Quiz, and many more to his name. So welcome, Dr. Amog. So over to Dr. Rakshit to start with his perspectives.
Thanks so much for the introduction, and thanks, YOSI, for the opportunity. And before I begin, I think I must express to SK Rao sir how much I enjoyed his talk. I think from the time I was a postgraduate, I've always been enthralled by all the talks and how he effortlessly able to mingle both the basic science and clinical aspects. So I really learn a lot from you always, sir.
Thank you.
Yeah. With that said, moving on to the article itself, I think I have a few specific points that I'd like to make. I think the devil in the details of this particular study, even though it's a randomized controlled trial, basically lies with the statistics. And if you were to go through the paper itself, in page number 4, and I'm sure it's an open access article, so everybody can take a look. If you look at the values, especially of the subjective scores for dry eye, which is basically the OSDI, the visual analog scale, and even mammography, you can see that some of these values, like Dr. Preetham also mentioned, that the values are very close together. In fact, you have in the paper itself a standard deviation in many of these mentioned parameters that I just said, the OSDI, VAS, and mammography. The standard deviation is double that of the mean, which basically shows that it's a very spread out data. It's a non-parametric data. And while they have mentioned that they've used the Mann-Whitney U-test, all the values that have been mentioned in the tables are actually in terms of mean and standard deviation. And I think they should really clarify what tests they use to achieve statistical significance. Because when you have in data of this sort, it's better to express it as a median and interquartile range and then perform the non-parametric test to get the results. That said, again, moving on with the authors' assumed conclusion that they cited a few articles saying that the kind of dry eye that you get with SMILE or lenticule-based procedures versus flap-based procedures is equal, and they clubbed and they didn't do a subgroup analysis. They justified not doing a subgroup analysis because of that. But there are also a lot of other studies that show, especially in the early postoperative period, there is definitely a definite subjective a difference in terms of perception of how comfortable patients are with lenticle-based procedure patients having a slightly better overall comfort when compared to LASIK, although this kind of fizzles out in the 1 month or 6 week postoperative visit. So with that said, again, even with the results that they've mentioned, the fluorescent breakup time itself, the magnitude of change between the control and test groups is just about a second, and the tear meniscus highest about 0.06. Again, as Dr. Preetham also summarized, these are probably statistically significant, but whether they do have any clinical relevance or any clinical basis to recommend this treatment is obviously questionable. I would say that to end with that, my take would be that probably yes, intense pulse light therapy does work and does have a marginal benefit as an agent in managing certain types of dry eye. It may improve your objective scores by a few seconds or so. There is no clear benefit, at least in terms of this study, as to the subjective symptoms of the patients. So would not really make any recommendations as to the treatment, as the authors also have not. They've not made any outlandish claims as to this could be a revolutionary treatment. They've just basically published their results in a randomized controlled trial. So that's about the points that I want to make. Thank you.
Thank you so much, Dr. Rashid, for further helping us understand the pros and the cons of this therapy in this particular situation. Over to you, Amog. Sir, Prasanna sir.
Amog.
Yes.
Point from Amog, yeah.
Yeah, hi. Thank you. First of all, thank you, YOSI, for having me on the panel, and always a pleasure to listen to Srinivas sir. There's always something new to learn from your talks every time, so thank you so much. So coming to the paper, kudos to Dr. Shruti for having decoded the paper excellently. And I agree with Preetham that the paper is robust. But there are a few points that I wanted to discuss. One is Dr. Shruti said the follow-up period was not enough, but I think at the end of 6 months, all the parameters were the same. So I don't think any longer follow-up would have given us any different results. Also, the only parameter, the OSTI is changed only in the 3rd month post-operatively, which is a subjective symptom. And basically, the tear film meniscus time and the infrared mammography were the only other parameters which have changed. But I think as long as the patient is asymptomatic, the changes in these parameters do not make a significant difference. So only the OSTI being changed at the 3rd month post-operatively does not carry much of significance, because again at 6 month post-operatively they come back to the baseline levels. So that is one thing. And the blinding that they've done for the physician is by using an opaque medium on the I think the handheld piece. So I'm not sure how the opaque medium that they've used would not be visible to the physician, or how that blinding was done. I'm not sure how that would have happened. Again, we are not using a corneal shield in order to prevent injury in a post-refractive patient. I'm not sure how much the risk would outweigh the benefit. And again, as Rakshit said, that we had to do an intragroup analysis of SMILE versus LASIK. They also have agreed that since the sample size was small, they couldn't do it. And I'm not sure how much this is relevant, but the study was actually sponsored by the company that made the machine. So as Rakshit said, the standard deviations were not too much, and yet the findings were significant. So these are my few points that I could make out from the study.
Thank you, Dr. Amog, for sharing your perspectives. Srinivas sir, your expert comments, opinions on this article, sir.
Very well presented by Shruti, and then the mentor and the panelists have discussed this threadbare. But there's always a clinical relevance and a statistical relevance. I think the point was highlighted there as well. So we need to make sure that while the paper may be showing what it really shows, the applicability in clinical practice, in day-to-day practice, is ultimately the goal of these papers as well. So if you see somebody with a disturbed ocular surface, with poor lid health, with meibomian gland dysfunction, then I guess, yes, an IPL therapy is meaningful. But if the question is, are you going to subject every single patient that you're going to do laser refractive surgery of the cornea on to an IPL procedure, which has cost, increased duration of time, and all that, then the question becomes moot. So I think that you have to look at the paper from that context as well, which I think the panelists showed you as well. So a statistical significance will show up if you have enough numbers, and anything can be statistically significant. But I think the reading clinician must make sure that it is clinically also relevant. Otherwise, it's not particularly good. But I think it's nice to look at the paper and dissect it and look at it in such great detail as it was done today. Congrats.
Thank you, sir. That means a lot coming from you, sir. Thanks a lot. So, Prasanna sir, can we proceed with the certificate distribution?
I'll just share the screen.
Yes, sir. So, I would like to thank each and every single person who has worked behind this scene for making this happen. Also, first and foremost, from the YOSI Journal Club, we wholeheartedly would like to thank Srinivas K. Rao sir for being our keynote speaker and giving us a fantastic presentation. Like Dr. Akshit was saying, connecting the dots between basic sciences and clinics is what we always have been in awe of, and nobody better than you to do that for us. So thank you so much. And we have this ritual of presenting e-certificate.
Thank you, sir. Thank you for not only giving a talk, but also being there for the journal club and guiding the young ophthalmologist in the article, helping them in dissecting it and taking it forward. Thank you. Thank you, sir, for your time. And we really value this relationship. And it's the video is there in an archive now. Your talk also, people who missed it live can go back and see it in the YouTube as well. Thank you, sir.
Thank you, sir. Next up, we'd like to thank Dr. Shruti Devi S. for taking up this initiative and being a presenter for today and presenting the article and thoroughly dissecting it for discussion. Next, I would like to thank Dr. Raghav Preetham for promptly accepting to be the mentor and also coordinating with the speaker, Dr. Shruti, and guiding her and wonderfully giving his perspectives on the article as well. And then to our panelists, Dr. Rakshit, who's been so meticulous in being noting down the points and presenting it in in a very professional fashion. Thank you, Dr. Rakshit. And Dr. Amog, again, for being so sophisticated and so detailed about giving your perspectives on this article as well. So thank you so much. And next up.
Yeah, we have our dynamic team,
Yes.
sir. As you can see, Ayushi is part of our team. She was not able to join today, but Ayushi, Anujit, Paul, as we speak, he's also here. So they all are a part of our dynamic team of YOSI Journal Club. And of course, we had Dr. Niranjan. The whole program was conceptualized by Niranjan along with Microvision, who helped us in the academic partner. Thank you, Niranjan, for conceptualizing such a wonderful module of dry eye, which is very relevant, and it was very clinical as well as from a research point of view. Thank you for it, Niranjan.
Thank you.
Myself, Dr. Prasanna, I am part of the YOSI Journal Club team, and we express our heartfelt thanks. And if you are a viewer watching this, we are an all-inclusive journal club. If you want to be part of the team as well in presentation, or if you want to mentor somebody or on the panel, do mail us your suggestions to yosi.journalclub@gmail.com, and we'll be happy to connect with you over the same. So thank you to Microvision as well. And a few comments from Srinivas Rao, sir, closing comments before we end the session.
I think I find this format very nice. I think this journal club is very important because much of our knowledge today comes from journals. The era of textbooks, I think, is, if it is not over, at least it is diminishing in its importance, because things are changing so rapidly that by the time somebody writes a textbook, it gets outdated most of the time. So I think we need evidence-based stuff. We need the journals. And like you have demonstrated so effectively today, it's not just because it came up in the Journal of Ophthalmology or in the Journal of Cornea that it becomes God's truth. It can slip through the cracks. So you must, as the reader, learn to analyze it properly to make sure that what you're getting, the information, is appropriate. So I think I like this format very nicely, very, very well. And I think having a keynote to some extent helps, having somebody with gray hair. So some benefits from the experience that they have. So ultimately, everything must be applicable clinically. I think that is the final take-home message. No matter what the article says, in your practice, in your patients, in your environment, in your hands, with your equipment, you must be able to use it effectively, wisely for your patients, which I think this kind of format will try and help the young ones do. So once again, thank you very much for having me. I thoroughly enjoyed being a part of it and learned a lot from the discussons today of the paper. Thank you.
Thank you, sir. Thank you.
Before we end, we have this photograph and Niranjan, a few comments from you. You conceptualized this whole event in this month module. Your comments before we go for the photograph. And if you have missed anybody, I think microvision, if you guys are there, you can also just on your screen. And also Numerotech, we would also like to acknowledge our technology partner Numerotech. They help us in all the seamless relay of the webinar and in YouTube as well as in Zoom. So thank you, team Numerotech. I hope Sai sir or Manjula ma'am is here. Thank you for that. And Microvision, Dr. Abhijit sir, thank you. And I think this has been one of the first time we have had a keynote speaker. Sir, we have had this from 4 years, but this is the first time we have brought a senior ophthalmologist, and we consider you as a YO, sir. We don't see you as a, so we see you as a YO. Thank you for being here.
Thank
And Abhijit sir, few words from you before we hand it over back to Niranjan.
Abhijit sir, can you hear us? Hello.
Hello, am I audible?
Yes, yes.
Yes, sorry. So, first of all, thank you for this wonderful opportunity. It was my first experience to listen through the journal club. A lot of information for me to take, which we often do not get the time to read, but it's a nice platform. And hopefully, we will encourage more doctors in the future programs as well and continue to be part of it. Thank you so much.
Thank you, sir. Niranjan, any other thing is left, or we'll close it with the photograph? Over to you.
Thank you, sir. Thank you so much. I think again, I would like to propose the vote of thanks to S.K. Rao sir, all the presenters, and Prasanna sir and Mr. Abhijit for bringing the entire event together. And I think we'll proceed with the group photo. So I request all of you available to turn on your video if possible, and we can have a YOS sign and we can proceed. Sir, Prasanna sir.
We have this YO symbol, sir, and the mandatory YO photograph. Dr. Akshit, Dr. Amog, yeah, Dr. Raghav, Shruti. So each one of you, if you can, yeah. Sai sir, we can go off live, and any attendees who are part of it, you can also switch on your screen. We would love to take a photograph with you guys.